Hello, my name is Dr. Peter Seidenberg. I am a family medicine, sports medicine, and adult developmental physician. I am the professor and chair of family medicine at Louisiana State University Health School of Medicine, and I am the North American Regional Director for MedFest for Special Olympics International. And I also had the privilege of being the Chief Medical Officer for the 2019 Special Olympics World Games in Abu Dhabi. Some disclosures. I am a consultant to Special Olympics International, and as I stated, I was the Chief Medical Officer for the World Games. I am also on the Board of Directors of Special Olympics Louisiana and was previously on the board for Special Olympics Pennsylvania. These cases are actual cases that I have taken care of during my 22 years of caring for Special Olympics athletes, but the pictures in the talk are not of the actual athletes. We're going to have a brief introduction, talk a little bit about sports medicine philosophy, and then we're going to use a case-based approach to talk about triage and care of athletes and some things that are unique to Special Olympics athletes. So my skills and experience, internationally, I helped create the standard of care for sports physicals for Special Olympics International. I am the sports medicine consultant to the Medical Advisory Board, and I am on the Global Medical Advisory Committee for Special Olympics International. And as I previously stated, I am the North American Regional Director for MedFest. I have been involved with Special Olympics for over 22 years now, and I have been involved in multiple states, pretty much anywhere that I've lived. So the sports medicine philosophy, the overall goal is athlete health and safety. We want to optimize health and safety, but we want to minimize lost time from competition. So in sports medicine, there's really two basic questions that you have to answer. The first is, can the athlete stay, or do we have to ship them out to the hospital? The second question that you then ask is, can the athlete play, or does the athlete need to sit? So it's stay or ship, and then sit or play. The other thing in sports medicine philosophy that you have to realize is in Special Olympics specifically, we do not want to blame everything on the athlete's underlying syndrome. There are some syndrome-specific disorders, but the majority of issues that we see in Special Olympics are the same as we would see in neurotypical athletes. So some communication tips for our athletes at Special Olympics. You want to be at eye level with the athlete. You don't want to be standing over the athlete. You want to be patient and wait for the athlete to answer your questions. But please do not finish his or her sentences. There's no baby talk. Most of our athletes are adults and deserve to be treated as adults. And there's no use of the R word. And that R word, for those of you who don't know, is retarded. That is not allowed. We do not endorse that word at all. Please use clear and concise language when you are speaking with our athletes, and be willing to reword what you said if the athlete does not understand what you're asking. And then finally, if you are not able to communicate well with the athlete, ask for help. Ask the coach, ask a parent, ask another athlete. They are often able to help you in those instances. So these cases, some of them are routine, some of them are extreme, but realize that the most common treatment I give in Special Olympics athletics is high fives, maybe some bandages for small cuts or abrasions, and ice, but it's mostly high fives. So the first athlete is John. John is a badminton athlete. He is in unified competition in doubles, and he's hit in the arm by his partner's racket. He ends up having a 3-centimeter simple laceration. So what do you do? Remember the two questions: stay or go, sit or play. So does this need to go, or can he stay at the venue? Well, if the bleeding is controlled and there's not much else injury-wise, he can stay. You can bandage him, and then you can bring him to the venue medical clinic to suture if those resources are available at your venue medical clinic. The next question is sit or play. John can play if he's willing to play, as long as the bleeding is controlled. So you do not have to wait to sew it up if you can bandage it and the bleeding is controlled. And of course, John wants to continue playing. It's always up to John if he wants to play. Now, it may be a little different if the injury was on the face. And so it really depends where the injury is. And so if the bleeding is severe and you can't control it with pressure and bandaging, then they're going to have to get it taken care of and not be able to play. The other issue to think of is the cut over the eye and affecting vision? If vision is impaired, they are not able to play. Remember, there is special care that has to be given to lacerations that involve the eyebrow or the lip. And so you have to use caution when sewing those. And so, for example, for the lip, you want to close the vermilion border first and then bisect from there. If you don't do that, you'll end up with a very poor cosmetic outcome, and the lip will heal kind of crooked. Our next case is Michael, who's a 20-year-old basketball athlete. Michael's going up for a rebound and gets an elbow to the head. He falls, and then his head bounces off the floor. He's holding his head and keeps his eyes closed tight. The coach says, he's just acting out. What are you concerned about? How are you going to evaluate this athlete? So some things to think about in John's case. Is this a behavioral situation such as the coach has alluded to? Is this a contusion? Is there a neck injury from the mechanism of his fall? Or does Michael have a concussion? So how do you approach this? You ask Michael what's bothering him. You quickly evaluate his cervical spine. And if there's no C-spine tenderness, you take him off the court to evaluate further on the sideline. If there is C-spine tenderness, you immobilize his neck right then and there on the court, and he's transported to the closest hospital. So obviously that's a go situation. So thankfully, Michael does not have any C-spine tenderness. He states that he has a headache, that his vision is funny, he feels dizzy, and he just doesn't feel right. On physical exam, his pupils are equal round and reactive to light, but he does get dizzier with lateral left gaze. When you shine the light in his eyes, he does have photophobia, and his balance is worse than his normal. And even his coach realizes that when you're testing it. So in Michael, our diagnosis is a concussion. So what are you going to do? Is he stay or go? Is he sit or play? Well, most concussions can stay. However, if there is vomiting or worsening neurologic status, that's a transport to the hospital. Otherwise, he may stay if he's supervised. And the reason for supervision is to make sure that he does not worsen. Now, he may leave the venue with family or with a coach if staying in the venue makes his symptoms worse. Sometimes the noise, the lights can make them feel worse. So sometimes it's better to go to a more relaxed atmosphere. So sometimes it's a little difficult to evaluate whether or not our athletes have concussions, because our athletes sometimes have communication difficulty and they have some baseline neurologic deficits. In general, when in doubt, sit them out. If you suspect there's a concussion, do not allow them to return to play. No concussed athlete is permitted to return to play. When can they return? Well, they can return to sport after they are asymptomatic and after they completed a graduated return to play program. That means at the very minimum, it's going to take at least a week for Michael to return to sport. So unfortunately for the national games, that means his games are done. Our next athlete is Sammy. She's a 45-year-old athletics athlete. Athletics is track and field. And Sammy is running in a 400-meter race, and she collapses face first before the finish line. She is not moving. What diagnoses are you thinking about while you are running out to evaluate her? The differential diagnosis in a case like this includes sudden cardiac arrest, seizure, hypoglycemia, dehydration, heat stroke, or quite honestly, she could have just tripped and she's embarrassed. Some other considerations include concussion and cervical spine injury from the fall itself. Just remember that a collapse before the finish line is much more worrisome than a collapse after the finish line. So because you're worried about a cardiac event, you bring the AED with you as you are running out. First question, is Sammy responsive? Consider circulation, airway, and breathing. Thankfully, she is responsive, but she's a bit confused. Breathing is a little heavy, and she's sweating profusely. Her heart rate's in the 130s, blood pressure is 100/68, and respiratory rate is 22. What are you concerned about now? Heat stroke is a thing that we really need to think about, especially during our summer games and especially in Orlando. What is the difference between heat exhaustion and heat stroke? Heat stroke has signs of end organ damage. In this case, altered mental status is a sign of end organ damage to the brain. So how will we treat this? Where will we treat this? Realize time is critical. You want to treat this person immediately on the sidelines. You want to either put them in an ice water immersion bath, or you want to use the taco technique, which is demonstrated in the lower right corner, where you use a wet sheet and you pour ice water over the athlete and ice towels over the athlete. This will quickly bring down their core temperature and prevent permanent damage. After you stabilize the athlete, you then transport to the hospital. Our athletes are often on medications that predispose them to heat illness. So please look at their medication list. Now, let's say Sammy actually got up on her own. You were running out to evaluate her and she got up on her own and she finishes the race. What are you going to do? Well, you walk up to Sammy and you ask her what happened. So I asked Sammy what happened and she's just said, I tripped. And she looked down sheepishly at the ground. And I said, are you okay? She said, yeah, I'm fine. I'm just embarrassed. I quickly evaluated her neck to make sure there isn't a cervical spine injury. I take a look to make sure there are no facial fractures, make sure she's okay, make sure there's no concussion. I pat her on the back and I tell her, great race. Our next athlete is Billy, who's a unified football athlete. He is a very active midfielder on the team. And in fact, he's one of the team captains, and he's the one who gets the entire team excited before each game. However, this game, he's very lethargic. He can't get off the bench during the pregame, and it's usually Billy who leads the pregame ceremony. So what are the potential causes of Billy's lethargy? It could be illness. It could be a seizure disorder. It can be Billy is over-medicated. It could be that Billy is under-medicated. Maybe he forgot his medication and he's withdrawing from it. Hypoglycemia is a concern, and also heat injury. So it ends up that Billy had a seizure in the locker room, and he's actually in a post-ictal state. Billy has been playing with his unified team for years, and his teammates are used to his seizures. So while he was having a seizure in the locker room, they placed him in the recovery position. The seizure resolved quickly. They brought Billy out with them to the field. He sat on the bench. So Billy's in a post-ictal state. Can Billy play? Unfortunately, no. He can't play. He can't protect himself. And so he's in danger of hurting himself. Is he disqualified for the rest of the games? Well, that kind of depends. In Billy's case, he regularly has seizures. This was not anything unusual for Billy. However, if Billy hadn't had a seizure in a long time, say 2 years, 3 years, he probably should get evaluated before returning to play. What sports should Billy not participate in because of his seizure disorder? Well, that depends if his seizures are controlled or uncontrolled. And if he has uncontrolled seizures, he should not participate in swimming, diving, equestrian, skiing, snowboarding, or cycling. Basically, any sport where having a seizure puts him at serious risk for injury or death. What if Billy is actively seizing? Should he stay or should he go? Well, it depends. How often does he have seizures? If it's not unusual, place him in the recovery position in a safe location. Someone stays with him. And if it resolves in a short period of time, then he can stay. However, if he has status epilepticus and it is not stopping, a rectal Valium is recommended, and then he needs transport to the hospital. Our next case is a golfer, JOANN. She is 19 years old. She has Down syndrome. She is complaining of trouble breathing. She's coughing. She appears panicked. What are the potential causes? Asthma, pneumonia, a panic attack. So how do we evaluate? We take her vitals. We notice that she's afebrile. Her heart rate's a little elevated. Her blood pressure is normal. Her respiratory rate is 22. She is not retracting. She has a wet sounding cough. She's a little tachycardic on cardiovascular exam, but otherwise no murmurs. And her lungs have diffuse expiratory wheezes. So what are our thoughts? Well, it appears that JOANN is having an acute asthma exacerbation. Should she stay or should she go? Well, if she has her albuterol but has not used it, give her 4 puffs of her albuterol. And if in 10 minutes she's feeling better, she could potentially stay. However, if she does not have her albuterol, or if using the albuterol does not help, she should go. Should she sit or should she play? Well, she should not play until her breathing is more normal for her and she is comfortable playing. Our next case is just on the next hole, and it's SWETHA. She's a 15-year-old golfer, and she's the foursome behind JOANN. She has autism, and she's started vomiting and has become very lethargic. She has new incontinence, and she's very, very thirsty. What do you do? What is causing her symptoms? Well, it could potentially be gastroenteritis, dehydration, heat injury, or is it behavioral? You evaluate her, and her vital signs show that she is afebrile, but her heart rate is a little elevated and her blood pressure is a little low. She is responsive but pale and diaphoretic. Her exam is otherwise normal. You obtain a glucose reading, and it's too high to register on the glucometer. So our diagnosis in this case is actually possible diabetic ketoacidosis. Should she stay or should she go? She should most certainly go. At the hospital, a venous glucose was obtained, and it was in the 800s. She was admitted to the ICU and was placed on an insulin drip. She was a newly diagnosed diabetic. She did not have a previous diagnosis of diabetes. So what does this case teach us? Just because SWETHA has an intellectual disability does not mean that everything is due to her intellectual disability. She can have the same problems as other athletes her age. It's just some problems are at greater risk with certain syndromes. And so it behooves us to learn about the specific syndrome of our athletes. Our next case is John. He's a 16-year-old athletics athlete, and John has autism. During a race, he sits down in the middle of the lane. He won't move from his spot. He is crying. The venue personnel ask you to help. What are you going to do? Well, I actually sat down on the track with John. I asked him what was wrong. And John was upset that Miguel bumped into him during the race. Miguel is his new friend from the athlete village, and he thinks that Miguel doesn't like him anymore. So you get Miguel to come on over. They apologize to each other. Miguel helps John up, and they finish the race together. Next case is Sarah. She's a 41-year-old equestrian athlete. Unfortunately, Sarah falls off her horse and lands on her head. She's alert and oriented. She's complaining of neck pain. What are you going to do? You evaluate her quickly, and on palpation of her cervical spine, you see that she is tender over the 6th cervical vertebra. Her neurologic exam, however, is normal. Is she a stay or go? Well, she's most certainly a go. She has bony tenderness of the cervical spine. You have to immobilize that cervical spine and transport her emergently to the hospital. What if she did not have cervical spine tenderness? Well, it becomes more of a judgment call. A fall from a horse is a significant height. And in Abu Dhabi, we had the policy that any equestrian athlete that fell was going to be evaluated at the hospital just to play it safe. But that is a judgment call. What if she has no spinal tenderness to palpation, but has bilateral paresthesias in the arms? Well, that is a major problem. That is a suggestion of a central cord injury. That case needs to be immobilized as well and transported emergently to the hospital. If Sarah has Down syndrome, what else should you be concerned about? So we're concerned about Atlantic axial instability, known as AAI. It is instability of C1 on C2 and is present in approximately 15% of individuals with Down syndrome. However, X-ray evidence of AAI does not disqualify an athlete, but symptomatic AAI does. And the reason for this is asymptomatic AAI has no increased risks of morbidity or mortality, but symptomatic AAI does. Thankfully, only 7 to 13% of those with X-ray evidence of AAI are symptomatic. So what are the symptoms? Numbness or weakness in the extremities, loss of bowel or bladder control, new onset torticollis, new or worsening muscle spasticity, a change in coordination, or a change in the ability to walk. Our next case is a 52-year-old judo athlete, Kyle. Kyle is thrown to the mat and lands on his left knee. He grabs the knee in pain. On exam, he's already swollen anteriorly. However, there's no ligamentous laxity. There are no meniscal findings on exam, and he's tender overlying the patella, but it's really swollen and boggy right where he's tender. So do you need X-rays? In this case, not really. The diagnosis is prepatellar bursitis. Is this a stay or go? Well, this one is a stay. He can most certainly stay at the competition. Is this a sit or play? Well, that depends on Kyle. If it hurts too much for him to continue, then it's up to Kyle and he will sit. However, if he thinks he can continue and you can pad that area and protect it, then he can play. Let's say Kyle decides he doesn't want to finish this competition, but he wants to compete tomorrow. You treat it with ice, some range of motion. You check him out tomorrow, see how he is, and if he's willing to go, he can play. So in summary, we want to use the sports medicine philosophy in our approach to our Special Olympics athletes. This case-based summary provided an approach for triage and care of our athletes who are injured or ill. Remember our two essential questions: stay or ship, sit or play. Remember, athlete health and safety come in first, but we want to minimize lost time for competition. Thank you for taking the time to listen to my presentation. I hope you have a great games, and if you have any questions, do not hesitate to reach out to me. My email is listed on the slide. Thank you and have a great day.